Hello, I am Dr. Mirela Cernăianu, and I welcome you to the Wellness Optimizing Warrior MD podcast, the WOW MD podcast. I am not your typical wellness coach, and this is not a typical wellness podcast. Here, I'll discuss educational facts about health, hormones, intimacy, anti-aging, and beauty trends, all very hot topics, to empower you to make great choices when it comes to your health and to your body. I want you to go, wow, I did not know that. Or, wow, this is going to make a great difference for me. Our healthcare system is broken and it needs a revolution. You and I can start one today. I am willing to share my knowledge with the world if you're willing to listen. Let's get started. Welcome to another episode of the Wellness Optimizing Warrior MD podcast. In this episode, I want to talk about our uterus. So this is mainly dedicated to women. And I want to talk about two very important uterine conditions that are very, very, very common: adenomyosis and uterine fibroids. And I'd like to provide you with some information about what they are and discuss signs and symptoms, maybe raise awareness about the fact that you might be suffering from one of these two conditions, and provide information about possible solutions. So I'm going to preface getting into the nitty-gritty of adenomyosis and fibroids by talking a little bit about pelvic pathology, signs, and symptoms. Then I want to talk a little bit about the pelvic organs and what they are. So we know as gynecologists that many women go through their reproductive life suffering from bleeding and pain. Most of the times, they don't really know that there's something wrong and that they have a serious medical condition until it is too late. Some women have really bad periods, sometimes long periods, sometimes heavy periods. Sometimes they're long and heavy at the same time. Some women suffer from very painful periods. Some women suffer from chronic pain in the pelvic area that comes and goes but never really goes away. And some women suffer in silence from painful sex, feeling ashamed and unable to share this burden with their partner, and sometimes not even wanting to share it with their doctor, which makes the pain and the bleeding and whatever other symptoms they have harder and harder to treat and address successfully, the longer the care is delayed. Every medical condition not addressing a specific issue early on will lead to the increased risk of that specific medical condition becoming persistent and chronic and getting worse over time. This is very true for pain. So please take pelvic pain seriously. Once you have pain that keeps happening in your pelvic area or in other places of your body, please be aware that new pathways can form, telling your brain that even normal, low-impact stimuli for those nerve endings in that area are damaging and painful, in spite of these stimuli being very innocuous in nature. And these pathways that are newly created lead to the persistence and chronicity of pain. This is especially true for any type of neuropathic pain where just a simple touch can be felt as painful, but in reality, it's a gentle, normal touch. Now, for women, it is very difficult to know whether you should take this type of symptom seriously, as many times women think it's a one-time thing. It was just a weird cycle. It's just a weird pain. Oh yeah, I had this pain a couple of times. Let's just wait and see. Well, this type of attitude and belief can be very damaging to you and can cause delays in diagnosis and treatment of a possibly very serious medical condition. This was just a short introduction to raise awareness about the fact that pelvic organ pathology symptoms can be interpreted as being somewhat normal and overlooked. So please be on the lookout. Any abnormal pain in the pelvic area, any unusual bleeding should be immediately investigated and reported to your doctor. So let's talk about what are the pelvic organs that a woman possesses and has. And in the next series Just like I did a super long series on hormones, I like to do a super long series about pelvic organs, pathology, and educate women on some very important issues. So let's start with outlining all the pelvic organs. Number one, the vulva. That is the vaginal canal external opening. It's the visible part of the vagina, has two skin-covered lips called labia majora, and two thinner, delicate, smaller or larger lips called labia minora. So that's one. Number two, the vaginal canal. The vaginal canal starts at the vulva, which is the external opening, and ends in the vaginal fornix or cul-de-sac, where our cervix resides. That is number three, the cervix. Our cervix is a barrel-shaped structure that sits at the entrance to the uterus. It has, just like a barrel, an external opening towards the vagina called the external os, and an internal opening called internal os towards the uterus. Number four, our uterus. The uterus is a triangular-shaped organ located inside our lower pelvis, and its only purpose is to allow development, nourishment, and protection for a baby. It is the organ that houses the baby for 9 months, allows implantation, and is a crucial organ for our fertility as women. That's number four. Number five are the fallopian tubes. The fallopian tubes are long and thin conducts, like little muscular tubes that are very soft, and they start at the top of the uterus. And in every image that you're going to pull on the internet, it looks like a body with extended arms, where the body is the uterus and the extended arms are the tubes. In reality, it doesn't look that way because these tubes are very soft and they just fall down behind the uterus. And at the end of the tubes, we have the fimbriated end, kind of like a little trumpet with little fimbria that literally act like fingers grabbing the egg that is released by the ovary. So those little conducts are very important for fertility. Number six, our ovaries. We are born with two ovaries, one for each side, our right ovary and our left ovary. The ovaries are the ones that make the eggs and all our hormones. The uterus and the tubes make no hormones, only the ovaries. Number seven, very important and very often overlooked, our pelvic ligaments that support the pelvic organs inside the body and keep them in an elevated normal position where they belong. Number eight, let's not forget about our bladder. It accommodates the urine accumulation and collects the urine that's made by the kidneys as a reservoir, allowing us to evacuate this urine in a controlled manner called voiding, which is under our volitional control. And number nine, last but not least, the urethra. It's a very small and short tube-like structure that starts from the bladder and ends at the vulvar opening. The urethral entrance into the bladder is controlled by our urethral sphincter. This muscle allows us to keep the bladder closed until we are ready to empty it by voiding. The purpose of this podcast series is to familiarize and educate you on very specific medical conditions that affect our female pelvic organs that are not normal and that are considered a disease. And please listen, because each one of our genital organs is prone to some very interesting and unique pathology that affects them. I am going to start at the center of our pelvic organs and work my way in and then work my way out, so to speak. So I will start with the uterus. And what I want to discuss in this episode is specific uterine pathology. And then I'll move on to fallopian tube ovarian pathology. And then I will discuss cervical, vaginal, vulvar, and urinary pathology. So bear with me, but I'm going to start with the uterus. Why? Well, it is at the center of the female pelvic organs and the bane of their existence for many, many women. As I mentioned before, the uterus is a muscular organ lined inside with a very special mucosa called endometrium. The muscle of the uterus is called myometrium. So remember these words, myo for muscle, so myometrium, and endo for inside the cavity, endometrium. So let's start talking about the possible uterine diseases. Usually there's a very wide and diverse range of conditions that can disrupt the normal functioning of the uterus, our womb, where the baby grows when a woman is pregnant. For our very intricately designed female reproductive system, our uterus performs a crucial role. Hence, any anomalies or disorders of the uterus can significantly impact a woman's health. And I'm not just talking about fertility here. I am talking all throughout the woman's life. The uterus bleeds once a month. Each woman is intimately aware of her uterus at least 5 to 7 days of the month, every month, for decades. So let's talk about what are the most common problems that can happen in the uterus. Number 1, adenomyosis, also known as endometriosis of the uterus. Number 2, uterine fibroids. Number 3, uterine tumors that could be malignant, and they're called sarcomas. Number 4, endometrial polyps. Number 5, endometrial hyperplasia. Number 6, endometrial cancer. Number 7, endometritis, which is an infection of the endometrium. And number 8, last but not least, uterine prolapse. This episode specifically focuses on 2 conditions, adenomyosis and uterine fibroids. Let's start with the adenomyosis or endometriosis of the uterus. As I mentioned before, the inside of the uterus is a virtual cavity where an embryo would implant and a growing baby will develop for 9 months. Imagine this cavity is covered by a plush mucosa called endometrium, or also called the uterine lining. And it's like a nice, soft, velvety carpet where the fertilized embryo would burrow day 7 after ovulation, so on day 21 of the cycle. Now, this type of lining only exists in the uterus. It's called endometrium, endo for inside, metrium for uterus, for a reason, because it only exists here. Now, when islands of this lining develop for some reason throughout the muscular fibers of the uterus, these islands of endometrium will suffer the same changes that the endometrium suffers throughout a woman's cycle. During the period, they will swell up, they will bleed, they fill up with blood, and now the uterine wall, instead of being solid like a muscle, it's more like a sponge filled with blood. Let's talk more about this. Adenomyosis or endometriosis of the uterus is not malignant, even though this endometrium literally invades the uterine muscle, a little bit like a cancer, but it's not malignant. So even though it's not malignant, it can be very painful and a very bothersome condition. It is estimated that somewhere between 25 to 35% of women of reproductive age suffer from adenomyosis. Again, to recap, this is the encroachment of the endometrial tissue, the inner lining of the uterus, into the muscle, into the myometrium. This invasive proliferation results in an enlarged and bulky uterus that leads to a variety of symptoms. And the very important thing for you to know is that despite its profound impact on women's quality of life, this condition remains underdiagnosed, largely due to many overlapping symptoms with other conditions. So it's often thought that the symptoms are caused by endometriosis, which is much more known and much more heard of, or uterine fibroids. So adenomyosis is least known, but much more common probably than both endometriosis and fibroids. So what causes adenomyosis? Well, the exact cause is not fully understood, but there are a couple of theories that have been advanced as an attempt to explain it. One more predominant favored theory suggests that long-term estrogen exposure through regular menstrual cycles or hormone replacement therapy might instigate some form of abnormal growth of endometrial tissue. This condition has been intimately linked to estrogen dominance. If you're not sure what estrogen dominance is, I talked about this in detail in one of my first episodes about estrogen. Another theory implies there's some kind of trauma to the uterine wall that happens during surgery or childbirth, which may disrupt the boundary between the endometrium and the myometrium, allowing migration of endometrial cells into the muscle layer. By the same token, there's some possible trauma that can happen when an IUD is deployed. It's much less likely if the IUD size and shape is chosen to fit a woman's uterus. So don't be afraid of IUDs necessarily. Let's talk about symptoms. How does it manifest? And how would you know that you might have it? Well, adenomyosis manifests through various, very nonspecific symptoms, which can range from 0 symptoms in some women to debilitating in others. Most frequently, women have heavy, prolonged menstrual bleeding, accompanied by clotting and severe menstrual cramps, sometimes extending to the lower back and pelvis. This is also known as dysmenorrhea. Those are painful periods. Sometimes women have pain during intercourse, called dyspareunia, or they simply could have an enlarged and tender uterus on exam. Chronic pelvic pain, often worsening during menstruation, is also very common. And some women may experience pressure symptoms, bloating, frequent urination, significant bowel dysfunction, because the enlarged uterus is pressing on all the adjacent organs, the rectum, the bladder, etc. So how do we diagnose adenomyosis? Well, adenomyosis is typically diagnosed through a combination of clinical history. So you come to the doctor, you tell him or her what's wrong, physical exam, again, a gynecological exam, not a family practice exam, and imaging studies. Ultrasound and MRIs can provide very clear pictures of the uterus, showing its enlargement and other distinctive characteristics of adenomyosis. When ultrasound is done frequently, you can see a lot of color inside the uterine muscle, signifying the presence of these islands of mucosa intermixed with the muscular fibers of the uterus. And occasionally, the diagnosis may only emerge when surgery is done for other pelvic issues and the uterus is removed, and on the pathology diagnosis, it says adenomyosis. And you're like, that's why I had all this pain and bleeding. So let's talk about treatment. There is no definitive cure for adenomyosis, and most treatments focus on symptom management. Now, ideally, we would treat the cause, but we don't know the cause for adenomyosis. However, it is generally believed to be estrogen dominance. And this is confirmed by how effective anti-estrogen treatments and progesterone-enhancing strategies can be at alleviating symptoms for adenomyosis. All hormonal therapies used by conventional medicine can be extremely effective. Birth control pills, progesterone, progestins, GnRH analogs, they can all help control heavy bleeding and reduce pain. I'll talk about GnRH analogs in a little bit. All these hormonal treatments have 2 mechanisms of action. Either they work on decreasing the estrogen or stopping it completely, or they work by luteinizing the endometrium and the adenomyosis implants by using progesterone or progestin effect. Let's talk about the first mechanism, where the estrogen is being decreased. These treatment options would be cutting off or decreasing the estrogen that these endometrial islands are thriving on. That is what the birth control pill, the Depo-Provera shot or the vaginal ring will do, or the GnRH agonists. Again, a little bit more about those in a minute. The other mechanism is to increase exposure to progesterone. Remember, I talked about progesterone in one of my previous episodes. It is a crucial hormone that balances the estrogen proliferative growth effect. So progesterone can luteinize the endometrium. It practically stops it from growing, stabilizes it. It can also, with time, thin out and inhibit the growth and proliferation of the endometrial mucosal islands that have invaded into the uterus. So it will prevent these islands from swelling up with blood and from causing the heavy periods and the pain. And that is why the IUDs that have hormones like Mirena or using a daily progesterone high dose or progestine would be very effective at treating adenomyosis. So again, under the influence of these hormonal methods, the estrogen will either decrease significantly, which calms down the proliferation and the growth of these endometrial islands inside the uterus, or in the progestin birth control method or progesterone, the lining is thinned out and shrunk, and that causes an improvement in the blood flow, which will be significantly less. So the uterine islands inside the uterine muscle do not swell so much with blood, so the periods would be less painful, and the uterus would not feel like a brick, a painful brick inside your pelvis. As I promised, I'll talk in a little bit about GnRH agonists. Those will be addressed when I talk about fibroids, because the GnRH agonists treat both adenomyosis and fibroids in the same way. Now, the pain caused by the adenomyosis can be treated by simply taking over-the-counter medication like ibuprofen or Celebrex, just as needed on and around the period. These are the most commonly known medical treatments that are used and employed by conventional medicine. Now, last but not least, if medical treatment fails to control the symptoms, surgery is an option. A woman can choose an endometrial ablation, which is a procedure that destroys the lining of the uterus. This is specifically considered as a good option for women with heavy menstrual bleeding who wish to avoid or delay a hysterectomy. But what you need to take away from this podcast is that the only definitive curative treatment is unfortunately hysterectomy or complete surgical removal of the uterus. Now, this is deemed as the last resort, but we are talking about a cure. And unfortunately, only removing the uterus is the cure for the disease of adenomyosis. And obviously, this is only recommended for women who have completed their families, who have severe debilitating symptoms, and are approaching or are past their 40s. Now, there are newer minimally invasive techniques, and laparoscopy specifically has made hysterectomy much less risky and less burdensome on the recovery time, as well as pain and risks and side effects. All laparoscopic hysterectomies are now pretty much same-day surgery outpatient. And stay tuned. I will dedicate an entire podcast on hysterectomy, so I will let you know when that's coming up. Now, we talked about medical treatment. We talked about surgery. Recent research has brought some intriguing non-surgical options to the forefront. Uterine artery embolization is one of them. That means placing a catheter in one of the arteries of the groin and advancing the catheter close to the uterine arteries and deploying small microsphere particles that would literally stop the blood flow through the uterine arteries or decrease it significantly and will cut off the blood flow to the entire uterus. And recently, high-intensity focused ultrasound, known as HIFU, came into the spotlight. Now, the long-term efficacy and safety of both of these treatments is still under investigation, but they've been around for almost a decade. The problem with this type of pathology is that it will definitely get better at menopause, when a woman will run out of estrogen for good. Many doctors will actually advise the patient to wait for menopause. However, what is not discussed with these women, and what I'd like to discuss today with you, is that should you have adenomyosis and should you need estrogen after menopause, your uterus is going to give you a very hard time. So let's think about this for a second. If you need estrogen replacement after menopause, you might be one of those women that is really interested in anti-aging and preserving cognition, energy, good mood, muscle mass, optimal weight, and sexual well-being. Then you might be looking into using hormone replacement therapy in the form of estrogen many years after menopause. And that will be a problem because should you have a uterus with adenomyosis, as long as you give it estrogen, you will continue to have painful, either breakthrough bleeding or menses. So you will have to keep the estrogen that's being replaced in a very low dose to keep your uterus happy, but that might not make you happy. So entering menopause with such a uterus is not easy because you're looking at possibly using hormones for more than 10 years after menopause, maybe 20, and it is guaranteed that the prolonged exposure to estrogen of a uterus with adenomyosis, it's going to drive you insane to the point where you're going to say, yes, doctor, please take out my uterus. It makes me bloat for a week every month. I keep bleeding randomly. It doesn't matter whether I'm on progesterone or not. When there is no bleeding, there's still bloating. Again, the progesterone can only do so much to balance the estrogen on your uterus. This is a disease that's extremely sensitive to estrogen. You might end up needing surgery anyway while using hormone replacement therapy for 5 years or more into menopause. I just want to mention that endometrial ablation might not necessarily help you drastically, but there could be some improvement in the flow of the period as well as less pain. I'm saying it does not help improve drastically the symptoms because it does not affect the uterine lining that exists throughout and within the muscle of the uterus. The endometrial ablation only burns the uterine lining cavity. So when time comes for a period and for the uterine lining to shed, there's really nothing to shed. There's just a burned scar. The islands inside the uterine muscle can still engorge, can still fill with blood, and create the sensation of pelvic discomfort and cramping, though there is no period. Keep in mind, this is a interesting pathology, and many women have no idea that they have it. It's a very easy diagnosis to make inside the doctor's office, just looking at the ultrasound, turning on the color Doppler flow, and see if the uterus lights up with red and blue. That just means you have mild, moderate, or severe adenomyosis. You can literally see it on the screen while the ultrasound is being done. So in conclusion, adenomyosis is in many women a silent disease, and though very prevalent, it should command our medical attention and should be a primary consideration for all women that have long and painful periods due to the significant effect and implications that it can have, not just on fertility, but the quality of life for all women. So I will end here this episode, and I will continue part 2 of this episode about uterine fibroids next week. I will see you soon. Thank you for listening. If you liked the information you heard and you'd like to hear more, please subscribe and follow my podcast. Should you find the content helpful to not just you, but possibly others, please share it and feel free to leave us a review. You are welcome to join the Facebook group, The Warrior Optimizing Wellness MD. I certainly hope that you've heard many things in this podcast that made you go, wow, I did not know that, or wow, I'd like to know more. So keep listening and I'll keep talking.